Hello everyone. Today we, in keeping with our respiratory month, are going to be talking about tracheostomy emergencies. If you are like me, this is how a tracheostomy emergency makes you feel. They are not one of my favorite emergencies, which is a big reason why I wanted to talk about this, because they do scare me. Ultimately though, when you think about tracheostomies, it's the ultimate definitive airway, so it should be pretty simple. So hopefully by the end of today's lecture, everyone feels a little bit more comfortable with how to manage these things and what they are and how they work. We're going to start off with some anatomy review. We're going to talk about the parts and pieces of a trach, what kind of patients get them, and then what to do in an emergency. So we'll start, as always, with a little bit of anatomy. If you look at the airway here, it's a side view through the head, but you've got the nasal passages that can meet up with the oral passages in the back of the oropharynx here. You've got your epiglottis that covers your trachea, where the air goes to the lungs, right next to the esophagus, where food goes to the stomach. And if we look a little bit closer, the middle of the neck, we have our trachea here, your laryngeal prominence here with the bone that you can feel, kind of like your Adam's apple there. Right below that is the cricothyroid membrane. And the reason this is important for us is that's where we do our crics in the field. If you remember, our indications for a cricothyrotomy would be a patient that we cannot oxygenate and cannot ventilate. So that's the membrane that we're going to puncture with our scalpel and our bougie and our 6-0 ET tube if we need to. The difference between a cricothyrotomy and a tracheostomy is essentially just the location. A tracheostomy is a surgical procedure tube that's inserted between the tracheal rings a little bit lower, just below the thyroid cartilage that you see here. Now, one of the most important things that we think about when we're looking at airways is it's easy to look at that nice picture of where we're going to cut these membranes, but one of the most important points is that these things are covered in blood vessels. So we see our thyroid cartilage here and our laryngeal prominence here. So this is the membrane that we're looking at cutting when we're doing our cricothyroid membrane, right? Our cric. Down here is where our tracheostomy is going to be, between the tracheal rings. Now again, why this is important, and this will come up later, but I want you to start thinking about it now, is look how close that tracheostomy is to this aorta here, where all of that blood is coming out of the heart. And one of your major vessels off the aorta is right by those tracheal rings. So this is a very vascular area in that anterior neck. And what a tracheostomy looks like, again, if we look at a side view, it's basically just a little short ET tube with a balloon on the end and a straw with a passage for an airway that goes directly into the trachea from the middle of the neck. Now, there's certain kind of patients that get a tracheostomy, and this is a very important differentiation point and is an important question to ask your patient when you're gathering your patient history. There's something called a laryngectomy, and usually this happens in cancer patients who have an oropharyngeal cancer that have undergone a major surgery to essentially remove their entire upper airway. So you see, if you look over here at this patient on the right, you see the nose, you see the mouth, this is the big tongue here, and they open up in the back of the throat in the posterior oropharynx. But all of these middle structures that you see over on the left have been removed because that's where the cancer is. And so essentially what you have is a tube that goes to the esophagus. The esophagus can go to the stomach, so you can still swallow here. But if you look, the trachea, so the connection to the lungs, has been pulled out and is essentially connected to the anterior neck. So there is absolutely no way to get air into the lungs from the upper airway. You cannot oxygenate, you cannot ventilate, you can't get any air into the lungs from the mouth or the nose. And this is a very important question to ask in your tracheostomy patients, is if they've had a laryngectomy, because that takes a lot of your options off of the table. And when you start to look at the pieces of a trach, you have different kinds. You can have an uncuffed trach, which essentially just means it doesn't have the balloon that the cuffed trach would have. These have usually been in a little bit longer, and these are usually on patients that don't require a ventilator. So these are your chronically trached patients who are just essentially breathing through the tube. These ones usually need some positive pressure and are hooked up to a ventilator. Each of these trachs has an inner cannula that is usually always in, and it'll tell you the size of the trachea on the outside of it, the size of the tracheostomy tube, and the type. That's an important thing to note. And then inside the box, these are not in every trach, but they do help when you're exchanging trachs. It's basically like the stylet that you would use for an ET tube, but with a tracheostomy, it's called an obturator, and it basically just adds some firmness with a blunt tip there when a trach is being replaced, just like a stylet would for an ET tube. So when you look a little bit closer at your tracheostomy tube, you see the tracheostomy tube here, and then on the outside there's a little detachable piece that you just twist and can pull out, and that's the inner cannula. Now the reason this is important is because this is where, if you need to bag this patient, it's the right size that's going to fit your BVM. So it's important to note that you cannot provide BVM respirations to these patients without the presence of this inner cannula. Now, there's different ways to get oxygen into these patients. Sometimes when you show up on scene, you might see this little kind of non-rebreather like collar close by over their trach. Essentially, that's what that is. It's just providing some passive oxygenation, just like we would with a non-rebreather, just giving them some supplemental oxygen. But some patients you might encounter will be actually physically hooked up to a ventilator, and you'll see that. You'll see a big machine by their bed. It'll usually be making noise, and there'll be a direct connection with their throat, providing respirations just like a ventilator would with a ET tube. You might see some patients with a little colored kind of wheel on the tip of their tracheostomy. Basically what that is it's a one-way valve, and these are for your chronically trached patients who can actually talk, and it gives them the ability to phonate. So these patients will be in fairly good health. They'll have the ability to spontaneously breathe, and they don't require mechanical ventilation. And all that valve does is give them the ability to get air past their vocal cords and make noises. Fenestrated trach kind of does the same thing. This is the step that they'll do in the hospital before they get that Passy Muir valve. Just helps get air past. It's basically the last step before a decannulation. It's kind of like the road test to see if the patient can tolerate taking the trach out. Now, if you see a patient that looks like this, I've only seen one or two of these in my career, but it looks like a little button on the inside of their neck, and you think, oh my goodness, what the heck is this? Well, it's called a tracheoesophageal puncture, and the reason that this is important to recognize is that it tells you the patient has had a laryngectomy. What you're seeing is the trachea, just like we saw in that picture earlier, has actually physically been moved to the anterior neck, and that little puncture there is the connection with the esophagus. So here's another picture of what we're looking at. It's a one-way valve. You can see the patient here who has had the laryngectomy, so air is coming actually out of the stomach. It's allowing them to phonate. So they're basically burping and able to make noises that will give them the ability to communicate a little bit better. Because remember, all these entire upper airway structures are gone, so the only thing that's able to pass through the oropharynx is actually a direct connection with the stomach, and the airway itself is pulled through to the anterior neck. So this little piece of plastic here gives them the ability to try to communicate and work with a voice prosthesis. So reasons that patients get trachs, what kind of patients would you expect? Ones that need long-term mechanical ventilation, so it's not a great idea to have a piece of plastic in the patient's mouth for a long period of time. So if it's very clear that they're going to need a ventilator for a long amount of time, these would be your bad stroke patients or bad trauma patients. They'll just go ahead and place a tracheostomy. Again, bad stroke patients or people at risk for aspiration or dysphagia are going to get trachs as well, just to keep them from getting pneumonia. Patients that have masses in their airway or bad cancers in their oropharynx. Obviously, patients who've had laryngectomies. And then sometimes you'll see it in patients that just have terrible obstructive airway disease, and their upper airway and their posterior oropharynx just has such big soft tissues, and it's so hard to get air in that it's causing them to have respiratory failure. Now, what do you need to know as a provider? Really, there's only 3 questions you need to ask. What, when, and why. So the first question, what? You want to know what kind of surgery they had. Is this just a simple tracheostomy and they're still in continuity above it, or did they have a laryngectomy and your only option at the airway is from the front of the neck? You also want to know what size of tracheostomy they have and whether it's cuffed or uncuffed. And you can tell whether it's cuffed or uncuffed just like you can on an ET tube if there's that little pilot balloon on the outside. You want to know when it was placed. That's very important for later when we start to think about replacing these trachs if we need to. And if you're showing up on a patient where their tracheostomy came out, you want to know how long it's actually been out. And number 3, why was it placed? What was the problem that led you to need to get this tube in your throat to start with? Just like any patient, when you go to these calls, I have to remind myself of this every time. Always go back to your fundamentals and your ABCs. Capnography might be helpful here, so you're looking for that nice smooth waveform with capnography between 35 and 45. Just a little reminder, if they're having some sort of obstructive process, you'll start to see that shark fin waveform, and it might give you a clue as to what's going on in that tube or in those lungs. And then you also might have a clue to hypoventilation or breath stacking. If their entitle's too low or it's starting to slowly climb like this, that might be another clue with hypoventilation as to what might be going on with your patient and why they're having trouble breathing. So there's 3 common trach emergencies that we need to know about and need to be experts at. By far the most common is obstruction. Just a ton of mucus plugging and obstruction in that airway, making it difficult for air to get where it needs to go. Sometimes tracheostomies can get misplaced or dislodged. And lastly, but I think most scary, is that they can bleed. And when they bleed heavily. So as we're evaluating trachs that aren't working well, there's this DOPES mnemonic that I like to use. DOPE stands for displacement, obstruction, pneumothorax, equipment, or stacked breaths. All of these things with a patient who's requiring supplemental ventilation can happen and cause increased worker breathing and respiratory distress. So if you're looking at a ventilated patient who is short of breath, step number 1 is just take the ventilator out of the equation. You already have an established airway. Maybe it's a ventilator that's not working right. So you take that out, you attach your BVM and see how well you can bag. If you attach your BVM, just like we talked about, you need that inner cannula to be there, and it probably will, but you can attach your BVM and see what kind of resistance that you get. So check your pressures here if there's an air leak around the cuff. If you need to reinflate the cuff and add some air there so air's not getting through, that might be the problem. The other thing to think about is obstruction, and by far this is going to be your most common emergency and the thing you need to be most facile at dealing with. So if you look at these pictures over on the right, these are mucus plugs that are just dry, like cellular debris that's just gotten stuck in the tube and has obstructed it. So what you need to do to handle this is deflate the cuff if you need to. Give them the supplemental O2 either by the BVM or the blow-by mask. Remove the speaking valve if it's on there, that purple thing that we saw earlier. Take that off because that's going to open up your airway. Actually take out the inner cannula. So stop your BVM respirations for a minute. Take that inner cannula out and see if you can pass some suction through there, because that inner cannula is going to be decreasing the diameter of that airway. And if you need to, you can inspect that cannula and see if it's got obstruction in there. Wash it out. Get that crusty stuff out of there and try to suction in the meantime. Mucus plugs are really the most common source of respiratory distress in these patients. So you want to be aggressive about trying to open up that airway and clean it out. Now, the reason that they form is because in a normal airway, the air that goes through the nose and the mouth gets humidified and warmed before it gets to the lungs. But if we're bypassing the nose and the mouth, that patient isn't getting the humidified air, they're getting the dried air from the surroundings. And it makes it super dry, and then the inflammation that comes with that makes it more prone to developing mucus. And then top that off, if you think about when you cough, you kind of close your mouth and your nose to increase some thoracic pressure. Well, these patients can't cough very well because that air is going to go right out through their neck, and they can't increase that pressure to make a cough. And so they're making mucus because of that lack of humidified air, but they can't cough it out. So what that leads to is really thick and really dry secretions that tend to sometimes get like concrete in that airway. One of the most important skills that you can practice or think about how you're going to tackle this is how to suction a trach. So you want to try to have the patient cough. Take that inner cannula out like we talked to, because that's going to increase that diameter. Put a soft suction catheter in, not too far, just past the tip, and you're going to insert up to 5 milliliters of normal saline from one of your flushes, and then just suction that out 2 or 3 seconds at a time. And what that's going to do is just loosen up that mucus and allow you to suck it out a little bit easier. Now, if you're having trouble with suction and you're pretty sure that a mucus plug is your problem, you want to consider trach removal. I would not advocate for this, but if you're having a hard time, you can consider it. You absolutely do not want to take that trach out or replace it. If it's already out, you don't want to put it back in if that trach is less than a week old. Now, the reason for this is that there's a danger. All those soft tissues in there, fresh post-operatively, are very inflamed and fragile, and it'd be really easy to get that trach back in the wrong place, and you might make a false trach. So don't touch a fresh trach. Really what you need to decide in this patient, if you're at the point where you must do something about their ventilations, try to go from their upper airway versus the trach side if you need to provide oxygenation and ventilation. If they're still in continuity, you can still provide some passive oxygenation through either a non-rebreather or a high-flow nasal cannula through their nose. One of the other things we talked about, the second most common problem, would be some sort of dislodgement or obstruction. You can see in these pictures here, the tracheostomy itself might have come out a little bit and be abutting the posterior wall of the trachea there, and it's obstructing airflow, so it might just need to be advanced a little bit further for that natural curvature to go right into the trachea. Or the trach might have come out and been replaced by a bystander or a caregiver and actually be physically in the wrong place. So always consider dislodgement or misplacement when you're trying to troubleshoot tracheostomy problems. Always remember that if you don't have that laryngectomy patient and your patient is still in continuity, you have a lot of tools in your toolbox to still address this airway. So even though they have that hole in their neck with a direct line to their trachea, you can still go from above if you have that option. So all your normal tools should work here. NPA, OPA, you can bag. If you need to, based on their mental status, you can place a LMA or even intubate from above. Now just realize if you do decide to ventilate from above, you don't want the air from above to be going directly out that hole. You want it to be going in the lungs. So if you do decide to go from above, which is absolutely fine, just put your finger over that hole or something so it goes into the lungs and not out the neck. Now, if you need to, if the oxygenation from above is not an option, you can go from below. So if you need to, you already have an established trach, it's older than a week or two old, you can use a bougie as your placeholder and place a 6.0 ET tube through the stoma, just like you would for a cricothyrotomy, only your incision's already been made for you. Now the important thing to remember is your carina is going to be just past where you put that tube in. So really once you get that balloon past the skin, that's where you're going to stop. So you're going to have a fair amount of your 6.0 ET tube hanging out of their neck. So do your best to stabilize it. If it was me, I probably wouldn't let go of that tube until we got to the hospital. Now, if you do reach a point where you need to replace a trach, the way to do that, normally I would, in this situation, there's probably going to be a caregiver there who is more facile with the trach than you. So I would let them do this because they're trained to do it. But if you're in this situation where you absolutely have to, you can do some lube to the outer surface of the trach. You place that obturator in there, the piece we talked about earlier that's kind of like the stylet with that blunt tip on it, into your tube. And as soon as you can, you're going to remove that once you get the tracheostomy in place. Or if you don't have the obturator present, you can still use a bougie just to guide that trach where it needs to go. You're going to slowly rotate it in, put the inner cannula into place, and then confirm placement just like you normally would with a good chest rise, capnography, and breath sounds and oxygen levels. So one thing to remember when these trachs do come out and you get that call for a dislodged trach, even if it's been there for years, it's important to think about that airway because it can shrink up to half its diameter within 12 hours of dislodgement. So if it's been out for a while, you might want to move fast, realizing that that airway is getting smaller and smaller while you wait. We already talked about confirming placement, so just like with any airway maneuver that you do, you want to look for chest rise, breath sounds, measure your end-tidal, and get a good O2 sat. Remember that if you're going to have to bag this patient, you need that inner cannula in place. The last emergency we need to talk about is bleeding, and this can be massive, and you need to be ready for it. We pointed out earlier on the anatomy slide that where this trach is in the tracheal rings, it's right there next to the aorta where the majority of our blood flow is coming to the brain, and the artery that it sits closest to is called the innominate artery. And there's something called a Tracheo-Innominate Fistula, where trachs that have been there for a while or for whatever reason were placed a little bit low can erode that tissue over time and basically cause that blood vessel to explode. Risk factors for this would be any patient who's got weak connective tissues. So if there's some sort of infection going on in the neck, if they've had radiation to that area, or if they're chronic steroids for whatever reason, that's going to weaken those tissues and make them more prone to breakdown and degradation. The other thing that can be a risk factor for this would be increased tracheal wall pressure. So if the tip is in the wrong position, it's not well positioned inside the trachea, but is rubbing up against that posterior wall, that can cause a problem. Also, if the cuff is overinflated, it increases pressure on that wall. Or long-term ventilation, all these things with any kind of mechanical trauma to that trachea can erode that tissue and get into the blood vessel. So warning signs. 50% of these patients that have a Tracheo-Innominate Fistula will have a minor amount of bleeding before the dam breaks. So if they're coughing or there's any sort of friction that can worsen that, that increases their likelihood of this kind of bleed. What the textbooks will tell you is that you might see a pulsating tracheostomy tube, but really the truth is that's only seen in about 5% of these cases. Usually if it's going to happen, it's going to happen within about a month of tracheostomy placement, but I can tell you, like, it truly can happen at any point in this patient's course after they've had their tracheostomy. What I can tell you is that it's a devastating injury. I've seen 2 of them in my career, and they're pretty awful. The overall survival is only 14%. The important takeaway for you is if you have any bleeding at all, even if it's minor around a tracheostomy site, take it very seriously and be prepared for a massive hemorrhage. And what happens if you are facing a massive hemorrhage? First thing you want to do is call for help if you can. You obviously want to have a lot of PPE. This is going to be a bloody mess. There's going to be blood everywhere. Your patient's going to be coughing blood. They're going to be vomiting blood. Blood will be spewing out of everywhere. So you need a lot of suction. You need 2 large bore IVs to give a lot of volume if you can. And then some supplemental oxygen if you can as well. Now, what do you do if this happens? Your first move that you can try is, if it is a cuffed trach, you can overinflate it with up to 50 cc's of air. And the idea of what this might do is start to tampen out the bleeding and put some pressure on that vessel to clamp it off. Now, if that initial move of overinflation doesn't help, you can slowly withdraw the tube and try to get that balloon positioned directly over where the bleeding is coming from, again, just trying to tampen out it. If slowly withdrawing the tube doesn't work, there is some teaching that you can pass the oral ET tube distal to the lesion, but I think in this situation you're not going to have enough time and the patient's not going to be still enough to let you intubate from above. So what I would do is move to immediate digital compression. So you've overinflated your cuff, you've tried to slowly withdraw it, that's still not working. What I would do is just go ahead and pull that tube out and stick your finger in. And what you're going to do with your finger is try to find the area where it's bleeding and just put digital pressure on it. So you're going to use that manubrium, the bone, that's bone in the sternum where the bleeding is coming from, and use it to pull that vessel against the bone and clamp off the vessel, essentially. And then from there, if you can get control of that bleeding, don't move your finger, and that patient's going to need to go immediately to the operating room. So just like any severe hemorrhage, this is what we've been talking about, but your goal is going to be direct pressure. So here's a picture of what it would look like if you're able to overinflate the cuff. If this is a vessel that's bleeding right here and you're coming in from the neck, just inflate that balloon, put a lot of pressure in that airway, and ideally it would clamp that off. Now, if that doesn't work, your next move is going to be pull it out just a little bit, see if you can adjust it and get it in the right spot. But if you can't, just yank that tube out and use your finger. Put your finger in the hole and use your finger to clamp the vessel and use that direct pressure. Now, don't forget, we're still talking about a patient with shortness of breath. So even though they have a tracheostomy, that's not always their problem. So it's important to remember that their heart and lungs could have problems as well. Could be a PE, could be a pneumothorax, could be STEMI, pneumonia, anemia, all of those other things could be causing them to have respiratory distress as well. So just because they have a trach, don't get zeroed in on that. If your initial actions aren't helping, broaden what you're thinking about and think about the other things that might be involved. And that is all I have. Here are some resources if you want to learn more about trachs. This is a fantastic website. I know we've covered a lot, and this is one of those things I feel it's helpful to have your hands on all the parts and pieces. And so the 7/8 actually have some trachs for training in their car. So if you want to learn more or talk more about this, reach out to them and ask them if they can bring the trachs so you can play with them and see how they work. And also, if you have any questions, just reach out to them. I know they'll be happy to talk. All right. Thank you for your time.